Now, please join me in welcoming our final speaker for this session, Dr. Danuta Skowronski, Epidemiology Lead for Influenza and Emerging Respiratory Pathogens at BCCDC, for a presentation on the RSV vaccine.
Thank you, April, and hi, everyone. I have to say, as the last speaker of the day, I don't feel a whole lot of pressure, but I do wish for you that the day has not only been informative, but also empowering. And I do get the sense that that's the case. Certainly my preceding panelists, I think, continued in that vein, and I hope to cap it off that way as well. I'm going to be presenting quite a few details, some math, arithmetic, let's say. Don't be daunted by that. Really what I want is, I hope, is to give you an approach to addressing the new vaccines against respiratory viruses that are in the pipeline, and there are quite a few of them, some already authorized, some about to be. But we cannot, as a public health community, continue to operate as if we're in constant crisis mode in responding to these authorizations. So I want this to be an empowering approach for you to handle the onslaught of new vaccines in a methodical, thoughtful, deliberate way, because we're entitled, and in fact we are responsible to do that. So I have no commercial disclosures to declare, but I do want to upfront disclose my sincere gratitude toward the team members. Yes, they are here. For their truly awesome teamwork in contributing to this analysis and presentation. So thank you very much. The question for the group then, and again, this is just meant to be an example, and you can apply this to other approaches also, or other vaccines on the horizon also. But okay, so should, and I need your help with this, should provinces publicly fund a program of RSV vaccination for older adults? This is our challenge to address, and as I say, there's considerable pressure on us to move ahead with this, isn't there? So when we're approaching a new vaccine program, we have to consider the usual parameters. When we're asking, should we? Okay, well, from whose perspective should we, and for what purpose, what goal or objective? Is it to reduce the individual risks of RSV infection or severe outcomes? Is it to reduce the population impact of RSV? Is it to reduce the healthcare burden of RSV? Is it all of the above, and is that possible? But there are special considerations also for this particular program we have to reflect upon. As yet, there is no NACI statement related to RSV vaccine for older adults, and I guess I'm beginning to understand why. NACI has been especially busy, I guess, with pneumococcal vaccine considerations, which I'm sure is also very, very important. There's limited evidence also, so we don't have a multitude of post-marketing trials to take into account. We have some pre-marketing clinical trials, but we have to somehow make do with the paucity of evidence to inform a program that becomes permanent and precedent-setting. And then we also have to consider relative prioritization of the use of this vaccine in addition to other vaccines and other important public health programs that have to be considered, because there are additional RSV technologies, monoclonal antibodies, vaccines for additional target groups, infants, pregnant women. So how do we rank this group against that group, or alongside that group? And then even within that group of older adults are not amorphous homogeneous group. There's variation in risk by advanced age, by comorbidity, by socioeconomic status also. So other issues to consider. And then again, we don't operate in a vacuum. We don't have the privilege of pontificating absent a consideration of cost. And cost has become increasingly important in the post-pandemic world for us to consider. So these are all issues we have to grapple with. And again, in the absence of a NACI statement or evidence, so good luck with that. As I say, there is limited Canadian evidence for RSV burden in older adults, but we are fortunate to have this analysis by El-Sharif et al. To draw upon, and we and a number of others have been citing this evidence because they do report risk or incidence of RSV hospitalization and other severe outcomes by age group in those over 50 years of age. And here's basically what they did. They were drawing upon the Canadian Immunization Research Network, a serious outcome surveillance network, and they were using data between November and May from CERN across the 3 seasons that I've specified there. And it's quite a simple analysis. They just looked at, of all the hospitalizations with acute respiratory illness across their CERN network during those periods, what proportion tested positive by PCR for RSV. Well, that's just numerator data. So to convert that into an incidence, they then just took, well, what is the sum total of ARI hospitalizations from CAIHI's database? And they divided that by the census data for Canada by those different age groups, multiplied that by the proportion, and voila, they got the incidence of hospitalization, etc., for RSV in those age subgroups. Pretty straightforward. But you know, it doesn't have to be complicated, does it, to be quantifiable and understandable and useful. That's really important. So here's some of their initial estimates before I get to the incidence estimates. First of all, very simply, they found that about 5% of hospitalizations with acute respiratory illness had RSV detected. And it was similar by age subgroup here, so about 5%. And of those, about 15% were admitted to ICU and about 5% died. So let's just pause for a moment and reflect on this very simple information, which is packed actually with meaning. If about 5% of ARI hospitalizations were associated with RSV, what does that tell us about the likely impact of RSV vaccination on hospitalizations? For instance, during the November to May period, the peak winter period, when our healthcare systems are overwhelmed, how likely is RSV vaccine to be the ticket to get us out of that? And remember, ARI itself is only a small proportion of all hospitalizations. So we can't rely just on the RSV vaccine to address how lean our healthcare system is. Maybe it'll contribute, but it's not going to make it go away. So we shouldn't be banking on that. I want to point out also, compare the proportion of ARI hospitalizations that were associated with RSV versus those associated with influenza. Even though we have a vaccine for influenza, influenza is still an area we need to work harder on, and we might achieve better bang for the buck, actually, if we get better influenza vaccines, mRNA, etc. This is another simple analysis before we get to the incidence information from El-Sharif, and this is just showing, okay, now of those cases of RSV, what proportion were the very old versus other subgroups of those over 60 years of age. And you can see that relative to the Canadian population, the very old, 80 plus years of age, are disproportionately represented amongst those RSV cases. The risk is not homogeneous across all age subgroups of older adults, and this is very similar to what we know for influenza. Again, note the very large number of influenza A and B cases compared to RSV cases, again underscoring influenza is still a greater burden risk in older adults. But it's really the very old, and we know this also now for COVID as well, right? It's a similar kind of pattern. So this is their incidence estimates by age subgroup. I do want to point out the final row here, there's something quite amiss, I think, in what they have generated as their incidence estimates. So we have written to the authors. So if anyone else is using this, just pay attention. That there's something, and I'll let you figure that out later, but there's something amiss here. Either way, you can see the risk estimates, and we are then extrapolating these to our population to be able to get a sense of the burden we might be able to avert, for instance, across Canada and within British Columbia. But I want to emphasize also that more than 95% of those who were hospitalized in whom RSV was found had underlying comorbidity. And that's higher than the proportion with comorbidity in the general population. So when we are extrapolating these estimates from El Sharif to our population, what are we doing? We're overestimating likely the risk associated with RSV in that older population. So just please keep that in mind. And that's important because this is information that was presented just last week at the ACIP meeting in the US. There is a big differential in risk amongst those with or without comorbidity. So if you look here, the gray bars are those who are otherwise healthy by age group. You can see that those with one or two or more underlying conditions are at about 3 to 5-fold greater risk than those who are healthy. And there are some robust healthy people over 75 years of age in the population still, so we can't treat them as if they're all the same. And same differential in the younger, older age groups also. So if we extrapolate the El Sharif estimates to the BC population and we apply a correction factor, because let's say our assay isn't perfectly sensitive, or by the time you're testing, the virus has already left and you can't pick it up. So we multiply by a 1.5-fold or a 3-fold correction factor to increase the potential incidence. And this is probably extreme, actually. The US is more often using the 1.5-fold increase, but we thought, well, let's increase the incidence, because as we increase the incidence, we're lowering the NNV, and so we're going to be having a conservative estimate of the number needed to vaccinate. But so we estimate between 1,000 to, say, 2,500 that might be hospitalized with RSV in those over 65 years of age in British Columbia. How does that then compare? I mean, how useful is that? You kind of need something to gauge it against, right? Well, COVID has not yet established the same kind of seasonality as influenza and RSV, but we can look at, over the past 6 months, say since August to February, how does this tally of RSV hospitalizations compare to tallies of COVID-19? I don't know about you, but I was quite surprised by this tally in British Columbia of COVID-19 hospitalizations, which far exceeds the number of RSV hospitalizations we would anticipate in a 6-month period during the peak winter season, except if we apply this very extreme multiplication factor to the estimates. So COVID-19 also is still causing a greater burden than is RSV based on these simple estimates. Well, you're aware of the vaccines that have been authorized only since August of 2023. And imagine we're being asked to consider implementing a program, and the vaccine has only been approved for 6 months and absent a nasty statement. But I'm not bitter about that at all. These are the vaccine efficacies, and when you're used to working on influenza, these are very decent and across 2 seasons, and that is sort of the imagined program. Right now it's a 1 dose, and let's see how long between doses. And by the way, in the clinical trials, when they went back to give another dose in the second season, they didn't really achieve a boost effect. So for sure, we're likely looking at 2 years, but maybe it'll be even longer, perhaps 3 years. But you can see there's some waning, but still, this is about the protection we get each year with influenza, isn't it? And I mean, that would be a good year. I want to emphasize that the clinical trials under-enrolled adults over 75 years of age, so these efficacy estimates may be lower in those over 75 to 80 years. And in US CDC analyses, sensitivity analyses, they've assumed maybe even half that in the very old. There have been some vaccine safety considerations, and of course it's the most severe that we would be factoring into a potential influence on our recommendations. In particular, a small number of inflammatory neurological events, and notably Guillain-Barré syndrome, a couple of cases during the clinical trials. But this is a rare event typically, so it wasn't possible to determine whether that was a chance or a causal finding. But the US has implemented a program, as you know, this past season based on shared clinical decision making. And so they do have some post-marketing data to help inform, is that a true risk of Guillain-Barré following vaccination, or were those just chance findings during the clinical trials? And this is just a summary of what they again presented last week of that safety signal. So post-marketing, they're identifying an excess risk for both of the vaccines, and you can see the estimates here, but I think they very appropriately compared that to what is the preventable severe outcomes per million vaccine doses, which are shown to quite clearly dwarf the risk associated with Guillain-Barré syndrome. And so and similar conclusions, as you know, have been made for influenza vaccine. So their conclusions were that there is an overall favorable benefit-risk ratio, but that Guillain-Barré safety signal has to be taken into account and requires more definitive investigation going forward. And of course, the benefits would most clearly outweigh the risks among those of advanced age or with comorbidity. So I want to talk with you about our estimates of number needed to vaccinate. In the absence of solid cost-effectiveness analyses, we undertook these to try to get a sense of how much resources would be required to introduce an RSV program. And we can, when we generate the number needed to vaccinate, we can actually multiply vaccination costs to get a sense of how does the cost to prevent one hospitalization compare against the cost to just treat. In other words, the cost of hospitalization itself. So you can derive ratios. And here is our estimates of the NNV. So we use the incidence estimates from El Sharif. And again, remember, they did not account for RSV attribution or comorbidities, which means these incidence estimates are likely overestimates, which means our NNVs are likely underestimates. So this is likely on the minimum side of the number needed to vaccinate. And then we furthermore applied these 1.5 and 3-fold increases to the incidence just to benefit the vaccine to the extent possible, right? And we multiplied by an assumed vaccine price per dose of about $250. Where did we come up with that? Well, in the US, they thought that the lowest it might go is $180. In Canada, the costs are typically lower, but you have to factor administration and all of that into it. This probably seems reasonable, but you can adjust it if you like. So here you see in the bars the NNVs, and these dotted lines are the costs when we multiply 250 just by these NNV numbers. And this red line is the line where is the cost of actually hospitalizing the individual. Okay? And these are the estimates of cost also from El Sharif et al. And what you can see just by eyeballing is that all of these costs, no matter the underlying assumption, they all exceed the cost to hospitalize. Now, we don't necessarily need it to be a break-even to be considered a worthwhile venture, right? You need to decide how much greater the cost to vaccinate can be than the cost to just hospitalize to make it worthwhile fiscally. I'll just emphasize very quickly, our estimates of NNV are very similar to those from the US, and you'll notice that they're also very similar to estimates from Canada for influenza vaccination. And that's because although the influenza burden is higher for influenza, the vaccine effectiveness is lower. And when you do the math, that comes out to approximately the same NNV then. Of course, the difference is the cost, right, of the influenza vaccine versus RSV. And this is then the ratio of the cost to vaccinate versus the cost to hospitalize. And you can see that in these younger adults, and remember, these are likely overestimates of incidence and underestimates of NNV and therefore of cost. But you can see you're about an order of magnitude higher to vaccinate than to hospitalize. And that's from a population perspective. That's not to say there isn't suffering associated with those, but from a population perspective, we have to prioritize because lots of things cause suffering, right, that we need to mitigate. And where it becomes most closely to a break even is in the very old, those over 80 years of age. Now, there has since been published a Canadian cost effectiveness analysis. This was published in February. And I'll just tell you the bottom line. They found essentially what we found using our very brute NNV and cost estimation. And they were also drawing on El Sharif, and they did no further adjustment for assay sensitivity, however, again, over a 2-year horizon. And they were looking at both direct healthcare and societal costs, whereas our NNV analysis was just hospitalization-associated costs. And they were looking at a program for long-term care residents or long-term care plus community dwelling adults. And they did something I think that is interesting. The most important part of their analysis was they worked out what would be the maximum price per dose in order to align with cost effectiveness based on standard thresholds of willingness to pay at $50,000 per quality adjusted life year. And they also looked at it at a higher threshold of $70,000 per quality adjusted life year. And these are the maximum prices per dose to meet those typical thresholds for cost effectiveness. Well, I think we can assume that the vaccine is going to be priced at least $200. Well, let's just say it has to be less than $200 in order to consider it cost effective in that larger age group of 60 plus years. They also did some sensitivity analysis at greater than 65 or greater than 75. And the only time that the maximum price per dose approaches what we're anticipating it may be is if we use a higher threshold of willingness to pay and obviously a higher age cutoff. Then we're starting to approach cost effectiveness. So should provinces in that context publicly fund a program of RSV vaccination for older adults? Well, I would say it's not a slam dunk. And I would say also we should not be pressured into premature decisions that become precedent-setting and permanent. And we're not in a crisis mode here. We should be thoughtful and deliberate about it. Clearly, there's a vaccine-preventable burden of severe RSV-related ARI in older adults, and no question. And from an individual perspective, one may choose to purchase and avail oneself of this protective, even highly protective vaccine, remembering that the benefits more clearly outweigh the potential risk, including of Guillain-Barré syndrome in those of more advanced age and those with comorbidity. But from a population or public health perspective, that absolutely requires prioritization and allocation of scarce resources. The RSV burden in older adults appears to be less than influenza and also currently COVID-19. The NNV to prevent hospitalization appears to be comparable to influenza in older adults, taking into account the higher incidence but the lower vaccine efficacy for influenza. But cost effectiveness is contingent upon price per dose, which we're anticipating to be 5 to 10 times higher for RSV than for influenza. And that's where it becomes problematical from my perspective. At the currently anticipated costing cost effectiveness is not clearly established. It might be improved if, for instance, we focus on those with comorbidity at advanced age, then the NNV comes down. If protection lasts longer than 2 years, and if we have additional products that introduce competitive, i.e. lower pricing. But that's a lot of ifs. And in the context of great uncertainty, and moreover, a changing landscape, and moreover, limited evidence, and I'll say it one more time, and moreover, in the absence of a NACI statement, a graduated approach is most prudent, I would say, pending better understanding of cost effectiveness and also of those safety signals. And I'll just end it there.
Thank you very much, Dr. Skowronski, for your very informative presentation and especially highlighting the complexities that play into that.